Okay, since this is the last talk until the party, I'll try and keep it brief. And if you saw Tony's talk yesterday morning on long COVID, there is a bit of overlap because I am presenting the data that we generated in the lab, but I'm hoping to go into a bit more detail on the experimentation and the methodologies. So this project, the title that I called Unravelling Long COVID, kind of arose due to the ADAPT study that was established in Sydney in April 2020, and it was a prospective cohort study really trying to look at post-COVID-19 recovery. And we collected 147 participants with confirmed SARS-CoV-2 infection, and they were enrolled through St. Vincent's Hospital in Sydney, and some were enrolled at external sites. And we were one of the first in Australia and the world to define long COVID in about September, October 2020. And our definition of long COVID was at 4 months post-infection, there needs to be a presence of persisting symptoms, either one or a combination of the following: fatigue, dyspnea, shortness of breath, or chest pain. And our definition was a year before the WHO came out with their definition following a Delphi survey. And their definition was symptoms usually at 3 months from the onset of COVID-19 that last for at least 2 months and cannot be explained by alternative diagnoses. And this is actually a lot more broader than our definition. So this is a patient characteristic table. Out of the 147 participants, 31 were defined as having long COVID, about 21%. Majority were mild moderate, with only 8 that were hospitalized, so had severe disease. We had age and gender matched controls. And then we also had a unique subset of patients that were infected with common cold coronavirus strains. And these are endemic strains that go around annually. So 229E, OC43, NL63, and HKU1. We also had archival healthy donor samples that were frozen down PBMCs prior to 2019, so definitely did not have SARS-CoV-2 or were never exposed. We followed these individuals over time, and we collected samples at 3, 4, 8, 12, 18, and 24 months. And I think it's important to note that by 18 months, the majority of our cohort were fully vaccinated, with some actually having reinfection at the 24-month time point. And so it is important to note that even our matched controls that were asymptomatic at 4 months, during initial infection, they did have cold and flu-like symptoms, but these had subsided by the 4-month time point, so were asymptomatic and not defined as long COVID. And so this schematic shows you the immune profiling that we did on the samples at 3, 4 months, 8 months, 12 months, and 24. And we really relied on our expertise in immunology. We used cellular assays that I described in my previous talk. We also measured serum analytes, serum antibodies, neutralizing antibodies, functional plasma ACE2 assay, and then now actually we've done single-cell RNA-seq at 3, 8, and 24 months. That hasn't been shown in this schematic. So the talk will be separated into 2 sections. The first is looking at immune dysfunction up until 8 months, which was our first publication in early 2022. And then our preprint now that we've shown data up until 2 years post-infection. So with the first study, we showed that there was immune dysfunction that persisted for 8 months following mild and moderate SARS-CoV-2 infection. And the first thing we looked at was plasma ACE2 activity. So we know that this virus uses ACE2 as a receptor to enter cells, and this receptor is actually an enzyme that breaks down angiotensin II, and really important in the kind of clotting and blood clotting pathway. And increased shedding of ACE2 into plasma may cause more severe cardiovascular diseases. And so we wanted to measure plasma ACE2 catalytic activity, And we did this using an assay that was developed by a collaborator, Sheila Patel and Louise Burrell at University of Melbourne. And so they have a validated assay that uses a quench fluorescent substrate-based assay, and it's done in-house. The plasma ACE2 activity, they've shown in other studies, that's elevated in patients after COVID-19 infection and compared to uninfected age and gender match controls with similar comorbidities. And plasma ACE2 activity also increases with the severity of the disease, as shown in this figure here. So we basically just sent them down our longitudinal plasma samples, and they looked at the plasma ACE2 activity for us. And what we saw was, yes, there is increased plasma ACE2 activity in COVID-19 infected individuals, but there was no real difference between the long COVID, shown in red, versus the matched controls in blue, and it decreases over time. So at 8 months, the levels of plasma ACE2 activity was very similar to the common cold coronaviruses and the unexposed healthy donors. So to conclude, plasma ACE2 activity is not a biomarker of long COVID. So then we wanted to look at whether there are serum biomarkers, and we used a multiplex bead-based assay that you can run on a flow cytometer, and it's by Legend, and it's called the LegendPlex kit. They have off-the-shelf kits with different panels, and the one that we wanted to look at was the antivirus panel that contained, that can detect pro-inflammatory cytokines, type 1, type 2, and type 3 interferons, and interferon gamma, which are important in adaptive immunity. We also designed a custom kit of another 13 analytes, looking at vascular inflammation, so soluble adhesion molecules, pentrexin-3, PTX3, that looks at, is a marker, and it's more specific than CRP for vascular inflammation, as well as other cytokines and other soluble markers that were shown in literature to be increased in severe COVID-19. So what is the LegendPlex assay? It's a multiplex bead-based assay. So each kit can detect 13 analytes. So you have 13 different types of beads that are coded with antibodies specific for each analyte. You add in your plasma or serum sample, and the antibody binds to the specific analyte. You have a secondary antibody with biotin, and you add streptavidin and PE for the detection of the concentration of the analyte. We do this in a 96-well plate. We have an automated plate sampler on BD LSR2 for Tessa, and then it measures the fluorescence of the beads. And we acquire about, I think it's 4,000 beads per analyte. And then this is the readout you see here. The beads are separated out by the different fluorescence of APC. So we know what the analytes we're detecting, and then the concentration is measured using PE. We have standards of known concentration that we run with every single plate, and the results or the concentration of the samples are interpolated from the standard curve. And so what we saw was nothing in a huge majority of the analytes that we looked at 4 months. So there was no difference between long COVID match controls, common coronaviruses, or unexposed healthy donors. But there were 6 that were different. That included type 1 interferon beta, type 3 interferon LAN1, CXCL9, CXCL10, IL-8, which is a neutrophil activation marker, and soluble TIM3, which is more T-cell exhaustion marker. And then at 8 months, the only markers that were different between long COVIDs and match controls were the type 1 and type 3 interferons. And this is quite surprising because interferons generally disappear very rapidly after the clearance of virus. So it was unusual to see elevated levels of type 1 and type 3 interferon in these individuals. And we think maybe it may be a result of immunopathogenesis of this condition. And so to have a more complex analyses to find biomarkers or serum analytes that are more highly associated with long COVID, we utilize a log linear classification model utilizing machine learning. And this was done by a mathematician, Dan Wilson, who was a postdoc at the University of Boston at the time, but he's since now joined us at the Kirby. He came up with a model, and I'm not a mathematician, so I won't go through all the explanation. But basically, we used the concentration of each analyte at 8 months, and he was able to do a log linear classification, model this using machine learning to see which analytes were more associated with long COVID. We evaluated the model by bootstrapping because we didn't want any false discoveries. And so this factors in FDR. He took out one patient each time as a training set. And then we did this 1,000 times over to make sure that what we're sampling is real. And what the model gives us is an accuracy measurement that takes into consideration true positives, true negatives, false positives, and false negatives. And it also gives us an F1 score, which basically tells us that the participants that we predict to have long COVID were correct. And so to visualize the machine learning model, so Dan actually used, I think it was Python and the scikit tool. We have this column graph to show out of 1,000 iterations of bootstrapping, the analyte that associated with long COVID the most was interferon beta. And we saw that with our just comparing concentrations actually. But with this model, we were able to find the 4 most highly associated analytes being interferon beta, PTX3, interferon lambda 2,3, and IL-6, even though, for example, IL-6, their concentration was really low, but when you use it in combination with the other 3 analytes and this machine learning model, we were able to have an accuracy of almost 82% to predict long COVID, an F1 score of 0.80. And then we're also able to use the data generated here to visualize and compare between the patient groups. And so linear classifiers define what is known as a decision boundary. And so the decision boundary is the linear line, straight line there. So a patient's analyte concentration at 8 months will lie on either side of the boundary, and its position relative to the boundary will determine whether the patient is predicted to experience long COVID or asymptomatic COVID. And so you can see the red dots are the long COVIDs and the blue dots are the match controls, and lying on the upper half of the decision boundary are long COVIDs, and we're able to predict that at an accuracy of 82%. And so what we did next also was immune cell phenotyping using 20-parameter flow cytometry, and we included markers of T cell activation, exhaustion. We looked at innate and adaptive immune cells, as well as activated cells. And this is just a gating strategy for B and T cells. So you have lymphocytes, single cells, live cells, and then we can separate B cells using CD19, and T cells express CD3, and then separate out the T cells to CD4 and CD8. However, we have 20 parameters in our panel, so but you do a 2D plot, and it'll be like 50 plots before you get your percentages. So a better way to analyze the data is to do dimensional reduction, and we do this now quite regularly using FlowJo, which is the software people use to analyze flow data. We connect that with R and use R packages that run dimensional reduction, very similar to single cell transcriptomics. And then we have a dimensional reduction graph here called a trimap, similar to a UMAP, but it maintains the more closer relationship to neighboring clusters than UMAP. And you can see I just gated there. The CD4s are more numerous. You can see it in the blue gate, CD8. B cells, the ones that aren't gated are monocytes, innate cells, natural killer cells, DCs. And at 3 months, we saw a striking absence of 5 clusters of immune cells in the long COVID that were present in the match controls. And these cells were mainly what we called unactivated or resting naive B cells, naive CD4 T cells, and naive CD8 T cells, as well as clusters of activated CD8s and CD4, CD8 negative innate-like cells. And over time, those unactivated or resting naive CD4 and CD8 and B cells basically did not reconstitute, whereas the innate-like T cells did come back over time and increase frequency, as well as the activated CD8s. So what we think is happening is you've got an inflammatory milieu that is turning over or pushing or activating these cells from naive cells into memory or more activated cells that is seen in long COVID and not in the matched controls. When you look at activation and exhaustion markers in T cells, CD8s have higher PD-1 expression in long COVIDs compared to matched controls, and also higher TIM3 expression at 3 months. And then when we look at the innate cells, this is showing gating of the innate cells. So they CD3 and CD19 negative. The monocytes express CD16 and 14. DCs express HLA-DR. Myeloid dendritic cells express CD11C, and plasmacytoid express CD123. And we're interested in plasmacytoids because they're the main producers of type 1 and type 3 interferon. And so we showed that these innate cells are more activated in long COVIDs compared to matched controls at 8 months. Monocytes are more activated as well as plasmacytodendritic cells, which kind of goes the same way as our previous data. So to summarize this part of the talk, so our data strongly suggests there's ongoing sustained inflammatory response following even mild, moderate, acute COVID-19 infection, which is not found with other prevalent coronaviruses. And people with persisting long COVID symptoms have a distinct signature. They have activated myeloid monocyte dendritic cells. They have high expression of inflammatory cytokines, particularly type 1, type 3 interferons. They have absence of unactivated naive T and B cells. And so we think this is a profile or a signature of long COVID that it's specific for. And what gave us good encouragement is that our data has been validated and reproduced by other studies. So, and they're international. So that study on the left is from a group in Portugal, and they also found elevated interferon beta in their long COVID cohort. Study in the middle panel from Germany found activated plasmacytodendritic cells. And then the study published in Nature by the US group showed also activated monocytes and higher T cell exhaustion is the same as what we observed as well. And so the last part of the talk is focusing on the 24-month time point, and this is a preprint on medRxiv. If anyone's interested in reading it, we're currently under review. So we wanted to ask what happens at later time points. And I want everybody to, basically keep in mind that all of our participants had natural infection prior to vaccination. They had at least 2 doses of vaccine, either Pfizer or AstraZeneca, by 18 months. And a subset of them, in both groups, long COVID and matched controls, were reinfected with Omicron between 18 and 24 months. So the interpretation of our data now is quite complex, and I'll show you why. And so because we did the first paper really, really rapidly, we were still accumulating all these other data on the side. We now have antibody levels at the 24 months. So you can see long COVIDs generally had a higher, spike IgG titer. It wasn't significant, but the levels were higher compared to the matched controls, and this was consistent over time. Once they got vaccinated, you can see that it jumps up at 24 months. So the total IgG to spike is no different, and the black dots are the patients that got reinfected with Omicron. And that's more striking here when you look at nucleic capsid IgG. So higher nucleic capsid IgG at 3 months in the long COVID compared to the matched controls. The significant is lost over time. And then at 24 months, the people that were reinfected had the highest nucleic capsid IgG as expected. And then when we use the live virus neutralization assay that Tony presented in his talk by Stuart Turville's group, we surprisingly saw higher neutralization titers in the long COVIDs at the early time points, 3 months, 4 months, and 8 months. This was lost at 12 months, and following vaccination, the titers jump up again, and of course, reinfection. We then want to have a look at B cells, because B cells are the cells that produce the antibodies, to see if the frequencies differ, but they don't when you look at total CD19 positive B cells. Yongxi Tan from University of Melbourne, our collaborator, used B cell tetramers to look at B cells that are specific to SARS-CoV-2, to both spike and nucleic capsid. and we didn't see any difference between the SARS-CoV-2 specific B cells at any of the time points, which suggests, and a lot of people think it's persisting antigens or persistent virus in these long COVID patients. There's no increase in B cell frequency, but they are producing a lot more antibodies. And then the 6 analytes that we showed in our log linear model to be highly associated with long COVID, there was still high interferon gamma and high interferon beta levels at 2 years, but when you remove the reinfected patients doing a sensitivity assay, the significance is lost. So that signature that we saw early on is lost at 2 years. And the same trend with activated innate subsets as well. So we saw higher activated monocytes, myeloid dendritic cells, and plasmacytoid dendritic cells at 3 and 8 months, but there was no difference at 24 months. The same with T cell inhibition and exhaustion markers, PD-1 and TIM3. So again, no real difference at 24 months compared to the early time points. And so then we wanted to have a look in further detail using single-cell RNA sequencing and TCR-seq, and all of the bioinformatics was done by Dr. Sarah Baluz, who's our collaborator from the Computer Engineering School. And we looked at the changes in these cells over time at 4, 8, and 24 months. And what we saw in the match controls was an increase in CD14 positive monocytes and memory B cells. But interestingly, in the long COVIDs, we saw an increase in those naive B cells and CD4 T cells that were absent at the 3 and 8 month time point. So they do reconstitute over time. And it's important to know that there was no difference in the innate subsets between long COVIDs and match controls at any time point. And then when we just zoom in on the 24-month time point using the UMAP, we combine all the cells and separate it into match controls and long COVIDs. We have almost 26 different clusters. There was no real difference now at 24 months. However, the naive CD4 T cells and naive CD8 T cells were still slightly lower in the long COVIDs compared to the match controls, but this was not significant. And then when you visualize this using UMAP of just the naive B, CD4, and CD8 subsets, there is no difference now between these naive subsets at the 24-month time point. We also had a look at the interferon response score. So this uses more than 200 different genes within the interferon pathway. And we saw at 24 months that the CD14 positive monocytes still had a higher interferon response score. However, this could be due to reinfection. But there was no difference in the other innate subsets. And exhaustion scores and T cells was no different between the two groups at 24 months either. And so then we want to have a look at the clinical data and the patient-reported outcomes by using this international standard EQ5D5L established by the Eurocrawl group. And they look at the 5 dimensions: mobility, self-care, usual activity, pain, discomfort, anxiety, and depression. At the 5 levels, no problem or extreme problem, and you're able to get the EQ5D score to relate to the quality of life of these patients. And we had a look at using this score, looking at the long COVID and match control patients over time. And what you can see is the match controls, shown on the left in blue, have a much higher or EQ5D score, so much better quality of life overall, doesn't change too much over time. And long COVID start off much lower, and it does recover over time. Some individuals don't really recover. And then when we look at other patient-reported outcomes, you do see an improvement in overall recovery, return to pre-COVID work, return to usual activities, and return to exercise. However, there's still 38% of the long COVIDs that are not able to return to exercise or return to work. So they're still very incapacitated and still very ill. And so to summarize, now at 24 months, we did see an elevated interferon gamma and beta levels, but this is skewed by reinfection. And despite the initial elevated anti-nucleocapsid IgG and high neutralization titers that we saw early on, there was no difference in these parameters at 2 years. Same with innate immune activation and T cell exhaustion. We saw a reconstitution of naive B and T cell subsets at 24 months, which does correlate with recovery of most of our patients. So 62 were recovered by the 2-year time point, but 38 are still very ill. So I think any optimism should be tempered by caution because we still want to know why these other 38% have not recovered. And so there's lots of theories on what is driving long COVID. And so a lot of people think it could be autoimmunity, dysbiosis, persisting antigen, viral fragments in tissues like the gut, or a slow recovery to damage, tissue damage. And the signature now that we and others have confirmed is elevated interferons at earlier time points, high inflammatory cytokines, lymphocyte activation and dysregulation, as well as myeloid cell activation. And so what we want to do now is compare the immune profiles we saw within the long COVID patients with the ancestral strain and compare it with other variants of concern. So we also have long COVID patients that arose from Delta and now Omicron. And so we want to see if the profile that we see is the same or different. And then we also want to look at the drivers of long COVID. So persistent antigen, autoimmunity. We actually have sent serum samples to a company in California called Seroimmune. And they have a very high-tech assay that uses peptide display on bacteria, and we're able to look for autoantibodies as well as viral antibodies. And then we want to look at the inflammasome-induced mitochondrial function, which relates to fatigue. And there's also been reports of reactivation of other chronic viruses such as EBV, CMV, and human endogenous retroviruses. So we've got a bit of data on that, but we want to do a few more assays to confirm that. And then I'd like to thank everybody involved in the long COVID projects, particularly the ADAPT study participants and the funding bodies. Thank you.
So, are there any questions for the speakers? Yeah.
Related to underlying conditions for these different groups, right? If you have looked at that, and also how did you monitor them, because I haven't read the paper, sorry, then for infections, right? For other infections in those 24 months.
Yeah, so we do, a majority of them do have comorbidities. And we have looked at that, and it's common, there's been studies that show that having type 2 diabetes increases your risk of developing long COVID. And it's hard to stratify because it's a very small sample size that we have. We're trying to collaborate with other cohorts around the world, but they're also fairly small. There's now studies that are recruiting bigger numbers. So the RECOVER study in the US are doing like 10,000 or something like that, which would help, I think, answer this question. But we're also, thinking of looking at, collaborate with other cohorts to kind of validate our findings. Because the patients are followed longitudinally, they are asked at every visit, if there are other complications or any other infections. And it's a lot harder now, I think, to collect or to start recruiting long COVID participants because people don't test anymore. So all of our patients have confirmed PCR results. And now because people don't test or even do the rat tests, when they have symptoms that persist or other underlying conditions, it's really hard to say that it's actually long COVID.
Hi, my name's Gareth Tudor-Williams. I'm from Imperial College in London. And I just wondered, is it okay to go back to the earlier talks?
Yeah.
So I'm very interested to know that there was a lot of controversy back at the very beginning when the mRNA, the Pfizer vaccine trials were pragmatically designed to do a dose at day 0, and if I remember rightly, a dose at day 21. And then, of course, certainly in the NHS in the UK, they could not roll that out. It was just impractical. And so you were basically dealing with a data-free zone where the population was being immunized with a strategy that was not reflected by the initial trials. But I wonder whether your cellular and humoral immune studies of acute COVID responses give us any insight for the next pandemic as to the optimal timing of primary and then the second dose vaccines? Because, we heard earlier about the incredible opportunities for mRNA vaccine production at speed and at volume that might get over some of those logistical problems if we're really properly prepared. But what is the optimal timing from your studies? Thanks.
I'm not sure I can answer that question. Casting my memory back to the literature at the time, and I think a lot of that literature actually came out of the UK because of that delay. I think there was some evidence that delaying the second injection gave you higher levels of antibodies. And so, and
yeah, but of course, antibody may not be what you need anyway. I mean, it's the speed of the cellular immune responses that probably matters most, isn't it?
Look, I've spent my life studying T cells, and I think T cells are probably important, but I think the best correlate of immunity that we have at the moment is neutralizing antibody for this particular infection. And that's said with somewhat heavy heart, but I think, and exactly the role that T cells play in immunity, I think is in immunity to SARS-CoV-2 is, I think we're still trying to sort out. And I think one of the take-home messages is there's a plethora of assays, none of which are particularly well standardized. And so, I don't think we're ever going to be able to herd those cats, but to get to some sort of consensus about what a standardized T cell assay might look like would be really helpful. I mean, I think to some extent that's happened with the antibody assays, but there's a lot of different antibody assays, and we've added to that chaos. To go back to first principles of immunity, allowing that primary response to sort of mature a bit more before boosting it, particularly in terms of somatic hypermutation and those sorts of things, and having limited antigen in the lymph node before you boost that may generate higher affinity clones, right? And, so I think there probably are some learnings from murine immunology and other sources of information that would suggest having longer between those immunizations would probably be better. But then you've got to balance that between that delay. So clearly one vaccination is not enough, and if you've got a pandemic that's taking over and killing people, then some immunity might be better than no immunity. So there's that balance, I guess, between rapid rollout and getting the most robust immune response. I mean, I think the real challenge for RNA vaccines is whether this short life of the vaccine immunogenicity, relatively short life of the vaccine, is something that's generic, is because this is a respiratory virus, and we see that with a lot of other respiratory immunity to a lot of the respiratory viruses, or is that one of the Achilles heels of RNA vaccines, that they generate relatively short responses? And I guess there's a bunch of phase 3 trials that are coming out of RNA vaccines for CMV, for flu, for RSV, that might help us answer those questions. So I don't think I answered your question, but it's a very good one.
Yeah, so I see your data saying that in long COVID, it looks like both T cell response and also neutralizing antibody level is higher in those groups. So my question is there any chance that somebody explore whether those people have reinfection rate lower or higher or any difference?
No difference between the two groups.
You,
They
you,
were both
you can
reinfected at the same
see the
rate.
difference. And
But I think you're asking a question, that has anyone in other cohorts looked at whether people with long COVID are more or less likely to be infected? I think there's probably a whole lot of behavioural things that would impact on that, because a lot of people with severe long COVID sort of won't be getting out much, and also will be very scared about getting reinfected. Certainly the patients I see are very scared about being reinfected, so are very cautious about exposing themselves to the virus. So I think designing that study would be challenging. I think you'd really need the controls would really need to be thought about very carefully. Otherwise, you might get some spurious answers like we got around weight gain with HIV, or some of the other instances we've seen with complications of antivirals that was talked about this morning.
Yeah, I agree with you. And also, following on your answers, that because we know that with infection, you're following with long COVID in some group of people, right? So there's studies try to convince that with vaccination, you tend to decrease ratio of long COVID. So my question is, for those who already have long COVID, is any effect of vaccination after they already have long COVID?
So not from our studies, but from other studies, I think there's differences in the literature. There are some that suggest that vaccinating people with long COVID doesn't make a difference, and some that suggest that there is some improvement. I haven't read any studies that suggest that vaccinating people with long COVID make them worse.
Thank you very much.
Okay, so if there's no more questions, it's my job, in the absence of the wonderful Sassy, to sum things up. I think there's been a lot of stuff presented. It's been a pretty intense couple of hours, so thanks for staying with us. I think in terms of a take-home message, I think, there's obviously, some very sophisticated techniques that are now available. And it's clear that, people that are experienced with those techniques can repurpose those very quickly. But I think in terms of being someone that's running a modern lab, I think you need to be across those techniques, understand how those machines that are becoming more and more black boxes actually work, but then also have the capacity to handle the enormous amounts of data and the complexity of data that comes out of those assays now. And so, I think the challenge for both research and diagnostic labs is, as it is with the rest of science, I think, is really making sure that we keep up with the information overload and manage that as we go forward, and really involve people. I think it's very important that laboratorians are trained not just in how the machines work, but also how to handle the data and make sure the data integrity is kept, is followed. But also, I think the other challenge, which we haven't dealt with in this, is that more and more these data are going to be put into algorithms. With our machine learning, I think we understand what we did because we did it. But with a lot of this, we'll be putting these data into black boxes and getting answers out, and we won't really understand that. And I think we need to really have people that are trained, that understand that part of the analysis. Otherwise, we're likely to get into a great deal of trouble. So, I think there's a lot of challenges going. The power of the technology needs to be harnessed in the right way. So thanks very much for attending, and on behalf of SASI, thank you all for attending, and I hope you enjoy the rest of the meeting.